Peter Block here at TCT 2015 for On the Scene, and we're in San Francisco. With me is Rob Byrne from Munich, and Rob has presented Isar-Desire 4. It is a trial with an unbelievably great name, so the desire is just all over this trial. Rob, tell me what the trial is to start with. This is a scoring balloon trial for in-stent stenosis. I do know that.
Yeah.
So why did you do the trial and how did you set it up?
So basically, there's been quite encouraging data for the use of drug-coated balloon as a treatment for in-stent restenosis. I mean, the advantage is obvious. You avoid implanting another layer of metal. However, the results in comparison with implanting another new generation DES have been slightly disappointing. There seems to be a slight edge in angiographic anti-restenotic efficacy if you implant another stent. And we thought, well, how about if we use the drug-coated balloons differently, prepare the lesion first with a scoring balloon? Are we going to be able to improve the efficacy of the drug-coated balloon?
So the real question is, does the scoring balloon make a difference, right?
This is the question that we looked at. I mean, there's two potential mechanisms of benefit. One, you could say, well, you improve acute gain because you extrude the plaque better. And the second, and the real hypothesis that we tested is, if you disrupt the neo-intima inside the stent to a greater extent with a scoring balloon, then this will allow the paclitaxel from the coated balloon to get into the plaque more effectively and give you a better clinical efficacy.
Okay, so there's the question. What's the answer?
So in order to answer it, we did a study with angiographic follow-up, 252 patients, so it's powered for an angiographic and not a clinical endpoint. And what we looked at is percent diameter stenosis at 6 to 8 months surveillance angiography. And what we saw was the percentage diameter stenosis was indeed reduced if you performed scoring balloon pre-dilatation and then drug-coated balloon as compared to standard pre-dilatation and then drug-coated balloon. The margin was modest. It was from 40% to 35% percentage diameter stenosis at follow-up. But it was statistically significant.
Okay, so what do you think is going on here, Rob? Do you think that you truly do extrude plaque? Do you think you just break it up? Do you think by scoring it that you may get the drug into better places? What do you think is happening?
Well, as you know, most of the prior studies with scoring or cutting balloons have been disappointing. And actually in our study, what you saw in terms of acute gain, at the end of the procedure, you weren't seeing any difference between the two strategies. So that suggests that the difference that we detected was something that went on during follow-up. And we think it's allowed the paclitaxel from the paclitaxel-coated balloon to work more effectively over the subsequent 30, 60, 90 days.
Okay. So I am an interventional cardiologist, as are you, and now I'm faced with in-stent stenosis, as are many of the people that are watching this. What's the right thing to do? Should we score? Should we not score? Should we use a drug-coating balloon? Should we put another stent in? What's your choice at this point, in the United States at least?
Yeah, so I think in the United States, drug-coated balloons aren't approved for use, so that certainly limits the options in the United States. But in Europe, at our center, our approach is drug-coated balloon, and I think looking at this data, I'm going to be scoring before I use my drug-coated balloon.
Okay, the scoring does seem to make a difference in terms of the later changes, and maybe it's just the drug gets into better places.
I think so.
Thank you, Rob.
Thank you.